and MC have done great work, great preliminary work. We made the announcement that we want presentation to be 10 minutes.
It's important to say the partnership works because we have a shared vision and a common goal. It's important to note that for every partnership to be successful, there has to be trust, mutual respect, understanding and respecting those differences, and a willingness to make changes to achieve the shared goals. And that, in a short form, is the essence of the PACFA project. In recognition of partnerships and the importance of partnership in achieving goals and objectives, this project, although AFP led in the PACFA project, is supported by family planning organizations such as Pathfinder International, Society for Family Health, NURI, and the Palladium Group. And I think this goes on to say we have lofty goals we hope to achieve, but not one group can do it alone. The collective makes the difference, and that is what we believe in the PACFA project. And as we come together to dialogue today with government taking the lead and AFP and all the other groups, I hope together in partnership we can build consensus that would lead to the change that we desire to see in the family planning platform in Nigeria. At this junction, I would allow the other presenters to take the lead. Thank you very much.
So, I'm going to be talking from the perspective of the scan that we did of the federal system, and to share with you the key findings as related to the administrative and the regulatory barriers. Essentially, this is what I'm going to do. Let's go to the next slide, please. Without taking your time, I'm sure we'll talk around some of these issues. That the reality about family planning in Nigeria today is that over the last 10 years, we have not made any significant impact, despite the fact that there are greater commitments from government, there are more commitment by partners, there are more interest around the whole issue. But in terms of the actual statistics, as we look at the ND shares from 2003 to ND shares in 2013, we had not made significant progress. And that raises the question, so what next? What are the issues? What are the barriers? And that's what this kind is all about. So this was commissioned by the AFP to look at some of the barriers that might exist in terms of the system for administrative purposes with family planning, and that is what I'm going to be talking about essentially. So the objective, please go on now. All right, the objective of this work was to identify, don't mind the word three, to identify three regulatory barriers in the administrative implementation system at the level of the Federal Ministry of Health that could be targeted for review in 3 years of the project that we implement by AFP. Three was the number you started with, but the idea was to generate as many as we can, and then let's look at three that might be most feasible for AFP to look at and determine to intervene around. Let's go on. So what did we do? Like I said earlier on, this essentially focused on scanning the Federal Ministry of Health itself as the main player and the catalyst for family planning activity in Nigeria. And what we did was to do a couple of interviews with many stakeholders across three areas: the Federal Ministry of Health officials, some of the major players in the field of family planning, for example, the PPFN and others, and also to talk to major donors like UNFPA. And we also reviewed the literature for what we know around the issue about barrier, as well as our policy and program documents within the country. So what did we find? Basically, we're looking at this from two dimensions. One, the operational administrative issues, and two, the regulatory issues, which will border around policy and policy interventions. So, in terms of the administrative issue, one of the first key findings revolve around the issue of funding. That clearly Nigeria had woken up to the reality of budgeting for family planning since the family planning meeting in London. But even though that is true, the budgetary provision had also not been that stable. The first year we had 3 million budgeted, the second year 3 million budgeted, but since then things have fluctuated a little bit more. But the greater challenge is not about the budget, but it's about the release. The first 1 year, 2011-2012, 3 million was budgeted from what stakeholder told us, and 3 million was released. Second year, 2 million was released. There was another 8.2 million that was voted from the SureP program, and release was about 50-60%. But for some other years, release was not as predictable or not as commendable. Clearly, the family planning program in Nigeria is heavily dependent on donors, and like one program officer says government pay my salary, but government doesn't fund my activities. The process of releasing and managing program funds is also not sufficiently transparent, as some funders had concerns about issues about how approvals are given and what influence the approval given by the top level leadership of the ministry. Next slide. The second one has to do with issue about data. The reality is that to plan well and to impact, we need data-driven programming. But there are challenges around data, talking about the generation, the quality of data generated, and utilization. Without any doubt, the evolution of DHIS2 has improved a lot of things around data, but there are still lots of gaps, particularly around private sector, because not more than 33% of them or so is today being uploading their data. But like I said, there are also greater issues around policy. But for family planning, there's also a whole issue around the issue of consumption data. UNFPA was funding for, when we were doing this survey a year ago, was funding a review meeting that was taking place every quarter in many states. But that was becoming unsustainable. And so at that point when UNFPA stopped, the question is, what should we do next to ensure that we get the data to truly do forecasting that will drive the agenda forward, and to ensure also that there is capacity within the system to do good forecasting. Yes, I was doing that as of the time we were doing this scanning, but we need to also ask what had happened since then. Next slide, ma'am. The third dimension has to do with the bureaucratic issues about processing of files and program-related requests. Many funders had issues around the processing of files at the ministry, and many program officers, even within the ministry, also seem to have a number of issues. The common denominator is that people say that the files are not treated on time, except they are followed up through individualized efforts, and sometimes files disappear between the time the program officer whittles down and the time they need the approval of the federal ministry. And two quotations to probably reflect that. Once somebody said, process of filing in the federal ministry is personalized and not transparent. Another one said, officers have to keep their files under their armpits if they want to be sure that it will be treated and will not be lost on the way. These are quotations for people. I don't work in the ministry, but just to report what people had said. Let's go to the next one. The next one has to do with the coordination mechanism. Nigeria is a big country. The structure is complex in itself in some ways, and therefore coordination becomes extremely important. And one of the core issues that came up is the whole issue about coordinating federal, state level activities. And one mechanism is the National Family Planning Meeting, which unfortunately, as of the time, and I keep on referring to that, as of the time we are doing this scanning, it was not holding regularly. And even when that meeting was being called, some states were not participating because their state commissioners had not approved money for them to travel for the meeting. There's also the National Outreach Working Group that has done well, but again, the regularity and the fact that sometimes it's dependent on donor is also a challenge to be reckoned with. The funders also feel very strongly that beyond the Outreach Working Group, there needs to be a network or a platform for the leadership of the ministry to interact directly with the leadership of the organization, not the program officers. So, Permanent Secretary with UNFPA rep and such category, they feel that it can give us a lot more leverage within the system. Next slide now. The other one has to do with capacity for programming within the ministry. There's no doubt that a lot of capacity within the ministry, but also there's also concern about how many people really have the capacity, and that what will happen in terms of succession plan, in terms of beyond the director, beyond the head of the unit, what happens when younger generation have to handle the program issue? What skills do they have? What are the opportunities to build their skills? Because without that, there will be issues. And there are concerns about how those opportunities are targeted, to whom and for what purpose. And there's a huge gap around supply chain management system, which is one area where there seems to be less capacity than many other areas. Next slide. So let me quickly in the next 2 minutes round updates. The regulatory issues, there are two main regulatory issues that were flagged at that point in time. One of them has to do with the role of patent and proprietary medicine vendors in family planning service delivery. What NDHS tells us very clearly is that these people provide services for more than a third of the Nigerian population, particularly when it comes to things like condom. However, there is again an evolution. The tax shifting policy that has been approved since then had given more role for the PPMVs. But the question is, how have they implemented the tax shift in terms of the regulatory barrier? And could they go beyond what we have approved now? Is there a potential that we can go beyond what was approved at that time to begin to look at even how to expand their capacity more than that? PPMVs used to be people who didn't go to school and people who are just maybe primary 6. That was what the regulation said that. But the dynamics of the population have changed so much. We also need to look at that in some different ways. But that is a major regulatory issue. The second one has to do with advertisement. Many of the agencies that are involved in bringing in and advertising branded contraceptives have a concern about the restriction as to when they can advertise. It can start from 10 p.m. onward, so that young people presumably will be asleep by then. Unfortunately, at 10 p.m. it's the fathers and mothers that are sleeping. The young people are up watching the television. And so the question is, do we need to review this? Because there are concerns that this might be limiting the reach of contraceptive messages to some specific population group that we might need to reach within the country. So let me end with just to say this, that clearly there are barriers. Those barriers define their impact and define the potential that we can do something about them. But the reality is, the more we can probably do something about, the more we probably can contribute to changing the picture in terms of the family planning dynamics and utilization in Nigeria. This is one of my slides I always like to quote. That who dares win, and so we must dare. It's not that things are difficult, that we do not dare. It's because we do not dare that ultimately makes things difficult. I want to thank you very much.
A comment relates to what the good professor discussed as the finding around the regulatory barrier on advertising, on the electronic media for family planning. I found the analysis of that finding a little interesting, in the sense that young people constitute about a third of Nigeria's population, and they do have family planning needs. I think we sometimes forget that young people or adolescents are not a homogeneous group of people. A lot of them are actually married, and in union, and so that probably takes care of some of our own biases about giving family planning services to the unmarried adolescents. But whether they are married or they are not married, they constitute a huge chunk of our population and they need those services. I'm not sure who the regulatory agency is. I think it is the Nigerian Broadcasting, NAFDAC and AP. I think our, particular recommendation or ask in this matter, is that advertising for family planning should ideally be a prime time thing. Irrespective of whether the parents are asleep or the young people are awake at night, it should be given priority, and you should be, advertised during the prime time so that it can get the widest possible audience. Thank you.
I'm going to be presenting on the 2016 health budget proposal as presented by the executives of the federal government. And this was the analysis that was done by Evidence for Action. And interestingly, I would agree with Professor Fatisi, who said that releases are really very important. Yes, releases are important. That is when the monies are released. But we have to start from somewhere. There has to be a budget, isn't it? And so for Evidence for Action, usually when the budgets are, the proposals are out, we do a quick analysis to find out what exactly has been put in there and how exactly can civil society engage the process. Because seemingly for now, within the ministries, it is still very not open for participation to civil society. And so at the level of where the budget goes to the National Assembly, we can then engage very robustly. And so this kind of analysis helps us as civil society to engage. Now, this basically shows us what were the assumptions that the budget was prepared upon at $38 per barrel, at the crude oil production rate of 2.2 million barrels, and then at an exchange rate of 197. Next slide. The focus of this analysis zeroed into three agencies of the Ministry of Health, Federal Ministry of Health, and that is the Federal Ministry of Health Headquarters, the National Primary Healthcare Development Agency, and the NHIS, that's the National Health Insurance Scheme. The traditional institutions of learning and all the other hospitals, tertiary hospitals, were excluded from this analysis for certain reasons, because obviously those are institutions that train our young people to become doctors, and especially some institutions that at the secondary level, the federal government takes care of tertiary institutions, and so we didn't want to go into some of those programs at the tertiary level, because we believe that MNH, maternal and neonatal health or newborn health, is primarily supported by these three key agencies that I've listed out at the federal level. Thank you. Next slide. And so I'll take you through from in the last 5 years. You can see the trend of how the budget has fared at the federal level. And this is strictly the Federal Ministry of Health budget. So as of today, the proposal that was presented to the National Assembly is 4.23%. I mean, sliding down from about 6%. And then you remember that we had commitments about Abuja, 15%. Where are we on that? Are we really looking at these commitments that we make all the time, or we just go back to develop budgets that we don't refer to send documents? Next slide. And this shows us the share of the Federal Ministry of Health budget is 257 billion as proposed, and out of the 6.07 trillion that has been budgeted for this financial year in Nigeria, 257 billion will be going to the Federal Ministry of Health, and all its agencies. But it will be important for me to point out that this is like a 2.2 to about 2.3 billion naira less than what was budgeted for last year, 2015. Don't ask me about the releases. We know that sometimes they don't actually come, yes. And then again, just to buttress the point, to show you that out of what will go to the Ministry of Health, Federal Ministry of Health, that little part that you see out there, about, forgive me, that's about 37, my eyes are for sight problems, not quite right, about 35 or so goes for capital. That's like one part of the 7 parts is just for capital. And then again, this shows us a brief comparison. We said, okay, fine. What has happened? I think I need to get down, please. Forgive me. Yes. Yes. So these are increased allocations to the agencies with direct growth for MSA. And so you find out that from 2016, we did a comparison of 2015 and 2016. And interestingly, you find out that the Ministry of Health headquarters got 11 billion as against 9 billion for 2015, 17 billion for National Primary Healthcare Development Agency, and again 852 million for National Health Insurance Scheme. Next slide, please.
Now, when you say, what exactly would the Federal Ministry of Health be providing for? What are the key things? Because we are looking at maternal and newborn health provision. Usually, they have been the ones championing some of these programs at the federal level. And so, out of the 26 capital items that they've provided for, we found out that about 11 of them were talented as law. Fine. And that amounted to 1 billion. 1.2 billion, as you can see out there. And then for upgrade of and modernization and equipping of 6 tertiary institutions, we see about 1 billion there too. And then again, 3% annual mobilization to permit. That's the public-private partnership project, and for which the government will be contributing 2.6 billion, and that was, I think that sparked of interest, because we're like, okay, what is this public-private partnership about? It wasn't quite descriptive, and so we put it out there to ask some questions. And lastly, we saw that about 376 million would go for training. Now, in all of these are, like I said, significant allocations within the Federal Ministry of Health headquarters. And then we were worried because in 2015 we had allocations for family planning. Now, we have the question, where is family planning in all of this? Where is the provision for contraception? Zero. And so we put it there and these are questions we are trying to find out. So for the National Primary Health Development Agency, we look at the budget again. 88% was going to go on capital, and we're very happy about it. Good job. So we expect that our children will be better cared for, isn't it? Then diving home into the provisions that were made within the capital provisions for budget, we found out that procurement of vaccines and devices would cost 4 billion. All right, and then developing national logistics supply chain, finalizing and adopting, designing, all of those like optimization, bringing in architects, determining optimal or redesigning recruitment and training of staff to fill gaps within the distance. All of that is a line item. I picked this out straight from the budget, right? And so you and I were, if you're doing a budget in your house, you will lump everything this way. And all of that will cost 11.6 billion. Now, so those were questions for us to start. This is all for capital budget. This is the National Primary Health Development Agency. Now, previous budget lines had community health, primary health care, under one midwife service scheme. What has happened? We didn't find that in the budget, and so these were issues for us. Next slide, please. And then for the and then a little bit of analysis went into that. We said, okay, you are giving 4 billion for vaccines, for instance, and let's say one of their researchers said that we have 6 million children needing vaccines in Nigeria. And so a lot of calculation will say that, I mean, at the federal level, for the purchase of vaccines, the government is not giving us up to 200 naira, which is not, it's about 156 naira. It's not up to the cost of a big bottle of liver water for your children. We know that development partners have been contributing to vaccine procurement. But how much? None of us know that. So is that in the public domain? No. So those are things that will also enhance some of this, because if there's transparency and we are able to publish some of these reports on websites, it will help the analysis. Therefore, what the federal government is putting on the vaccine, or is going to use to procure vaccines for the number of children we have in Nigeria, this is it. But for logistics, of course, they put 11.6 billion. And how much the states are going to be contributing, I don't know. We didn't do that analysis, which some of our colleagues may have some of those analyses on logistics. Now, there are some questions that we need to ask ourselves.
how much, I'm sure the government will know how much you think the organization will cost per time. The key within the organization that you need to give it to them is to know that at least I know how to count budget. And then again, we know that soon Nigeria is graduating out of the Gavi funding and all of that. How prepared are we to take up this responsibility, back on our own? Now I look at 2015 budget. We now look at that so that this is what was provided for MSS, within immunization, community health, polio, and Turkey, for maternal and child health programs. A lot of those, had, sorry, I just showed you 2014 and 2015. These were all provided for. But again, this year, none of in 2016, it wasn't provided for. So, for policy makers, we needed to bring this out for them to see, to tell us what exactly is happening. For the National Health Insurance Scheme, in 2014, actually, there used to be some huge budgets for them. But we realized that in 2015 and 2016, the budget has been mainly for capital because we have they generate money enough to pay themselves. Good. But for 825 million for medical equipment that they have put into the budget, what exactly is it going to be like? It was just written, for medical equipment. So we need those budgets to be disseminated because if you are practicing a participatory and transparent government for civil society as well as every one of us should be involved in budget. If they say it's our budget, isn't it? The public budget is yours, isn't it? I can't hear anything. Is the budget yours? Yes. So we have to be involved and we have to know. So again, we ask them, where is the fund for
You are on 2 minutes extra time.
Okay, where is the fund for exit? We didn't try to find funding for exit. So this is a summary of all of that. F is listening, IMS rate, antenatal care and all of that was not there. And then again, one key thing we found out was that the National Health Act, 1% that was promised was that this money will come from the Consolidated Revenue Fund, 1% of it will go to support the National Health Act. We didn't find that in the budget, and so we split up the next. Finally, we asked ourselves that these are some of the things we need to do. Family planning, consistency, we said 11.35 billion annual family planning budget commitment that is signed up to. Where is it? Consider 15%, the NHS, where is it? And so they were further developing because you know that by now we still have to present it to you, the actual budget, isn't it? But we are still in the process of, signing the budget. So we don't have that officially. This was just the proposal. But to tell you that this was taken on board to the National Assembly. We had robust engagement, Health Sector Reform Coalition, PAPA, AFP, they're all engaged at the National Assembly level to ensure that some of these things were discussed with them. And so hopefully we hope that there will be changes in the 2016, but we hope to see that I will share that with you for the Thank you very much.
I'm Dr. Ebuk, Director of Public Health at Akwa Ibom State. There's a question as Esther was presenting on immunization. She did say that she couldn't find the cost of immunization immunizing a Nigerian child. I wouldn't agree with that. I think she will need to follow up with the agency. That I mean National Primary Health Care. Because I know I was one of the members that developed the next country multi-year 5-year plan for immunization, 2016 to 2020. We provided that you should ask for that document because we did that with all the partners in Nigeria, UNICEF, WHO, and it's a very concise plan. There's a section on that. Again, the problem may be maybe they have not disseminated because I've not heard for a long time. We were to learn that thing after the election, but you know, like every other social sector, there's drop in finances. Maybe that's why they couldn't launch and disseminate. Secondly, when they launched the pneumococcal pneumonia, they did present cost of immunizing a Nigerian child vis-a-vis cost of each vaccines. I may not give you estimate now because new vaccines have come in. So the average I used to know may not hold, but go to them, the director of immunization, you get it from them.
For mine, also go to the presenter, Esther, about the budgeting 2016. A describing of this MSS and also a budget line for the family planning. So I just want to talk about the state. I don't know what about the state budgeting. One time I was in office of the permanent secretary, the director of family health. He made mention that the state government need to make a budgeting also for family planning commodity, and then also the scrapping of this MSS. The state like my own, they involved into community media free, as approved by Federal Minister of Health, and I think I do believe we have to see the community media free and the MSS, which one is more important. The community media free is to identify every member of community, the secondary school leaver, a girl or anybody, to educate him on the concept of immunizations, maternal and child health issue, to be also taken back, to, no matter how to reach community members is, they have to back to their own home community and serve their own community, provided that they are sufficiently informed, educated on how to take care of home birth and what have you. So I do believe that it will be more better, sincerely, than MSS. I have to say it, and I need more clarification to see this member of community, because for most of the MSS, there's some restricted area that they cannot go in. Really, mostly, let me give example to Northeast. There's some restricted area that MSS, but there are people there, members of that community are still there. If you educate the member of that community, that is a SSCE leaver, they will be taken into this College of Nursing and Midwifery. They will be taking course of 2 years at least, so of which they will be now taken back to their own community to serve their own community. So we assess both to see. So I think I do believe that if we could do more, you have to create a quality guideline to enable all the states involved in the community midwifery if it is approved by the federal government. Then the family planning commodity, we have to do advocate yes as well to federal ministry, but as well not forget the state government. They are funded, they have budget line for this. We have to advocate also for the respective states to ensure that they too, they have development partners working in every state, and they also have this provision for family planning. Why don't we also advocate to the governors? The governors themselves must create a budget line for family planning as well. We are doing with federal government, but don't forget the state government too. Thank you.
My name is Dr. Neka Oji. I'm from the Ministry of Health, precisely the Department of Health Planning, Research and Statistics. So the presentation tells us that the National Health Act was not budgeted for, and so it didn't appear in the budget. So upon the passing, the signing into law of the Act, we needed to do a lot of groundwork, you know, to set out the platform for the operationalization of the Act. And that took us a whole lot of time. And then we also understand that the whole of last year and a big part of this year, we had major financial constraints in the ministry. And most of the work we did were partner supported, you know. But having gone through all that, we have costed the operationalization process, and I'm happy to inform us that by the time we are doing the supplementary budget, the cost for operationalizing the Act will appear in the supplementary budget. So it's not as if it was forgotten. Thank you. And then again, part of the steps that we have taken is we have started institutionalizing a process whereby there's a bit more interaction between the Ministry of Finance and the Ministry of Health, such that it can also help us to increase our budget. So we have started interfacing in a much more friendly way, and we have also started developing skills around having evidence for us to ask for more budget. So we are riding on the path of evidence-based budgeting this time. We were asking for 10 naira. Why are we asking for 10 naira more? You know, what evidence do we need to show that we really needed 10 naira more to what we are giving? And then we're also working on the accountability framework. You know, that speaks to the presentation part where it talks about allocation and releases, so that people can be held accountable going forward. So that's just the bit I wanted to say. Thank you.
I think Esther's analysis is fantastic, and I think it also drives us to the point of starting early. So that, and I think that's why we are able to talk about to the assembly. But I also think that in addition, we need to talk to planning, because obviously we've not talked to planning. And that's what Dr. Neka is trying to talk about, what they're going to do next. I think that advocacy should start with planning, so that when they are coming up the budget with the executive, we will have had a stronger ground with them. That's my one. On the other hand, I wish this analysis also included what was released in 2015 and 2014. Because it's also going to be nice to go beyond what was projected for those years. Because like I was sharing with him, sometimes we look at the budget and a government error had the highest, 9%. Maybe that error released 1%. But we will be growing in the 9%. So I think that this analysis must also take us back to look at what was actually released in those years. Do we know? And possibly, what were they spent on? I think then we can begin to then push the government further and push them stronger. Thank you, sir. Am I supposed to respond to my comment now? Oh, okay. I had only one comment with, from Dr. Jega. Sir, I cannot agree less with you. I think family plan must be prime time. And we must advocate to APCON and advocate to NAFDAC around those issues. And part of the issue also is there's a whole debate about, can you even go and buy some contraceptive on the store beyond pills? So I'm not. Can you buy pills on the store from the store? What we do is because NAFDAC is not looking. The law doesn't permit many of those things. So we need to look around many of those issues and begin to advocate on them very strongly. Let me say, just on another issue, the adolescent issue. We've talked around adolescent a lot, and many people in this room probably know that that's probably what I work on more than anything. But we need to begin to look at that strategy all over again. This, what we have classically described as adolescent and youth-friendly. Today, the evidences around it have become a bit murky. That more work that tells us what to do, and it's a lot around integrating it. And it's not just about a pipeline. And so we need to, what we need to think about is how to make the entire system adolescent friendly. That's what we must be looking at this point in time. In May, by May 10, the Global Commission on Adolescent Health will release its result. I'm part of that commission. And these are part of the issues we're trying to deal with. So we must begin to help the entire system totally becoming adolescent responsive and adolescent friendly. Thank you, sir.
We should realize that we are also going to be held accountable for whatever we say here. So it's very important that we actually disseminate what we know as fact. There was a comment on FP, or there have been comments on FP commodity budgeting. I need to make it very clear that it is not right to say family planning commodities were not budgeted for. That is very wrong. Family planning commodities were budgeted for. We could talk on how much was budgeted, but to say that it's not budgeted for is not right.
It wasn't there.
Well,
it's not your budget.
Exactly. Also, you have to realize that there were a lot of issues on the budget that was presented to the National Assembly for defense by the Federal Ministry of Health, to the point that the Honorable Minister of Health, Professor Isaac Adewale, had to indicate that the budget they gave him to defend was not his own budget. We had a ceiling in our envelope for FP commodity budgeting, and we did budget for FP commodity. All these could be some of the reasons why the budget, in fact, is not yet out. I will be looking at overview of family planning as it affects funding and regulatory issues in our great country, Nigeria. I'll look through very brief introductory background and then the trend, graphic trend of contraceptive prevalence rate as well as our national target on CPR and look more in depth into policy environment and funding landscape. Then there are some challenges and opportunities that we have. I'll look at these two and before concluding, we consider some ways forward. Next slide, please. We are quite familiar with our reproductive health situation and as well as issues around population and development in our country. We know that annual growth rate of the population in this country is about 3.2%. This is very high. It means that by the year 2035, the population of Nigeria may actually double if we go at this rate. The question we ask ourselves is, our infrastructural development are also moving at the same pace? Can we match up with this pace of population development, or we need to change the trajectory? Also, maternal mortality in this country is so high. We have over 100 women and girls dying daily from birth-related complications. Then, with the high fertility rate, high unintended pregnancy and maternal mortality rate versus a very low contraceptive prevalence rate of about 15%. All this means we have a lot of work to do on reproductive maternal health in this country. So we need to look at ways to increase the uptake of modern family planning services so as to contribute our own quota to the change agenda of the present administration. We know, and it's been emphasized also here today, that we could avert as high as 30% of this maternal mortality rate and 25% of under 5 mortality, only if we employ fully the strategy of family planning. Next slide. This is showing the graphic trend of our contraceptive prevalence rate. By the NDHS of 2013, we remain around 15% of total CPR. For us to actually meet our target, we need to change this trajectory and move at the rate of around 9 percentage point increase annually for us to meet this target. However, I have a very heartwarming information on a recently conducted smart survey that will soon be released, that we are actually moving at a very high speed, and our CPR by that survey has actually increased. We are closer to our target than ever before. Yes, you soon get this once it's fully validated. I do not want to thank you very much. The other commitment we made, next slide please, as a country, apart from achieving 36% CPR by the year 2018, which is our main commitment that keys into family planning 2020, is that federal government will work more closely with state and local government to secure complementary budgetary allocation for family planning and other reproductive health issues. And also that government will partner with private sector, civil society, traditional and religious institutions in this country. And that is one of such that we are doing here today. Next slide. Let's look into the policy environment within the country. We have a very rich policy environment, and this has been affirmed not only by us Nigerians, but also by international community. You could see the array of policy that, in fact, some other countries have adapted from us, starting from the National Strategic Development Plan, which is the bedrock of all policy and strategic issues on earth in the country to our recent family planning blueprint, which is a major point of discourse here today. Next slide. So I will look more into a few of these policy documents, particularly the National Family Planning Blueprint, the tax shifting and tax sharing policy, as well as some issues around free family planning information, commodities and services in this country. Before I get there, let me also talk on postpartum family planning country implementation plan, which we have put together with partners. This will give us a very good window of opportunity to get information across to women and make them have improved access right from the time of antenatal care to the time of delivery. Next slide. Okay, thank you. On family planning blueprint, this actually, as most of us here are aware, is an evidence-based planning that ensure we are able to prioritize issues that were identified as bottleneck to family planning programming. Issue of low demand, I mean, we always come up. And the strategy recommended by FP Blueprint to this is sustain high-level support, improve public dialogue, like we are doing here, as well as targeted demand generation efforts, which of course may have to be adapted for each community, each locality, with appropriately acceptable terms and words to use. Then key provider is another major issue, especially when it comes to long-acting reversible contraceptive. And this was one of the reasons that gave back to tax sharing and tax shifting policy, which I'll be talking more about. And we have been having some shortages of FP commodity at service delivery points in the public sector. And we need to improve our logistics and strengthen last mile distribution. For enabling environment, especially when it gets to funding allocation, this has also been well elaborated here today. And to this, we actually need to review some policies and strategies around making the best use of the fund we have, and also getting more innovative ways to get improved funding. Then issue of staffing to handle data. This was also well elaborated earlier. We need to improve capacity systems and tools to manage data gathering as well as use of data to inform decisions. These are all what are well articulated in the FP Blueprint. So we went ahead after launching this National Family Planning Blueprint to provide some leadership to states. We look at some modeling through data dynamics to see what each state could actually contribute to the national goal of 36% CPR, and a number of factors were considered during this modeling. We got good support from Features Group there, now Palladium, that has a technical support unit working very closely with me in reproductive health division. So supply factors and demand factors were considered. What is the enabling environment in the state? Availability of commodity and accessibility to facilities and these commodities. Then demand factors like the current CPR going by NDHS 2013, and then percentage point change in CPR between 2008 and 2013. The unmet need in the particular state, total fertility rate, and then population of married women of reproductive age group. Actually, that was what was used, but I think emphasis should be more on population of women in reproductive age group. So that gave us these model results, which showed what each state is likely going to be contributing if we work at certain pace while implementing the national FB blueprint. Next slide. So let me quickly go to tax sharing, tax shifting policy. We know that tax shifting itself involves the rational redistribution of tasks among its workforce, as well as movement of some specific tasks where this is it's found appropriate with evidence, from highly qualified workers to head workers with shorter training and fewer qualifications, so that we could make more efficient use of the available human resources in the country. This is actually spearheaded by WHO, and it's been of good acceptability in different countries within and outside Africa. So for us, the objective of our tax sharing policy at the beginning was to ensure that we have approval and then we operationalize, thank you very much, we operationalize the tax shifting policy to empower you to administer contraceptive injectable and provide long-acting reversible contraceptive, thereby addressing the critical shortage of providers that we have in country to improve access to family planning. Next slide. Then on free commodity policy, this is initiative of the federal government to ensure that there's improved access to free family planning information, commodity and services, so that financial barrier is removed as a major bottleneck to family planning. This targeted only public facilities, but presently there is a pilot going on with shops strengthening health outcome through private sector, supported by USAID and the Federal Ministry of Health, to extend this initiative or policy to what were expected from each contributing partner into the basket funding, and also what was actually disbursed by different contributing partners. Next slide. Next slide shows that we are paying particular attention to commodity warehousing as well as distribution. You could see the pictures on top depicting what happened previously, very chaotic. Even our commodities, when we got them, we were not sure of keeping them well enough, but now things are better organized. Next slide. There are, however, some strategic interventions that are demanding efforts from you and I. We have started working on a family planning communication strategy and development of a national logo. We remember some yesteryears, few decades ago, there used to be a national logo of facilities providing family planning services. You have the logo there showing that, yes, this facility provides family planning. We are coming out with something like that, but a more robust communication strategy. We also come with this to improve demand generation. We also need sustain improved coordination on family planning programming. This we have started enjoying, but we need to sustain it and in fact improve a little more on it. We need to look more critically at stakeholders into evidence-based, adolescent-friendly services. Next slide. Engagement of faith-based and traditional ruler is quite very instructive for us to make progress. Alaji, thank you once again. And the trend of coordination needs our particular attention. This trend is improving. We need to sustain and improve it more. Advocacy and engagement with all stakeholders is quite very important. Coordination should also look at issue of equity and spread of support. We have a situation where most times support will be in Lagos and Kaduna State by all partners. All partners want to do the same thing in these two states, leaving other states unsupported. This will not speak to equity. We need to gently address this in our coordination efforts. And it's very important that we share lessons learned and challenges that we face as well as best practices, so that we not keep making the same mistake in different pockets of interventions at different parts of the country. There are quite, next slide, there are quite some challenges on scale up of FP. Issue of funding have been so well discussed. I need not go much into this, but let me inform you that our forecast for FP commodity that we need for this year stands at 15.5 million. Previously, it was 12 million, but because we are increasing access, all these factors were considered in the forecast for 2016, and the cost will also shoot up. We still have low demand for and capacity for delivery of long-acting reversible contraceptive, but this is actually being taken care of. We are having some improved contribution of LAC to total FP services in the country because of tax shifting that we are considering. Commodity security it remains an important challenge, especially at the last mile, where average Nigerian women in reproductive age group will access this family planning. Federal government provides free commodity up to delivering them at the state level, but states still expect that federal government will distribute to the facility. This is becoming a big challenge now. The issue of data as a challenge has also been considered. Our officers, especially at lower level, have limited capacity to collect data and transmit data for us to be able to use them. Next slide. Okay. There are very good opportunities that we have, not minding these challenges. For instance, the recent policies, National Health Act had been talked about here today. The tax shifting, tax sharing policy, I've mentioned it. We have developed national training documents for two to provide IUD as well as implant. And in fact, we have trained master trainers, about 80 of them spread around the state of the federation. There is a good political will supporting family planning now. Professor Day1, the Honorable Minister, happens to be a champion of FP himself. And we believe this will be an impetus for other stakeholders, especially state level government, to come more responsibly on board. And our coordination is also being improved upon. We are lucky also that donor community is prioritizing Nigeria because of so many reasons: political will, our population, and what we could contribute to FP 2020. I just came back from a focal point meeting in Kampala where this was also well discussed. Next slide. I think I can skip this because of time. Our further opportunity, anytime we introduce new commodity, evidence shows that we have, 2 more minutes please, Mr. Chair, that we have increase in CPR, and of course our method makes also improve. Sahana Press is being introduced into the country, and we are looking at this in a very holistic manner. So also progestogen vaginal ring, which we come more powerfully into the FP commodity. I have talked about PPFP. Next slide. I hope you will just permit me 1 minute to articulate what we think could be way forward for us as a country. Our state programs need to focus on innovative, homegrown, social and behavioral change communication to increase demand. And for us to sustain increase in service uptake, states need to actually develop their costed implementation plan. As we are speaking, 4 states have concluded their costed implementation plan. A few other states are also working aggressively on this. Tax sharing policy has come to stay in the country. States that have not adopted this, we need to do so quickly. Issue of advocacy for increased domestic funding for FP is very critical to us as a nation at this point. We have to make this as innovative as is possible. And also we consider private sector in this regard. Then our contraceptive logistic management system needs to be strengthened. So, permit me to conclude by saying with high political will, leadership, and stewardship role of government at all levels, as well as our own sustained passion. Implementation of family planning blueprint, we shall make our target of 36% CPR by the year 2018. Wonderful friends and colleagues, with effective coordination and sustained policy and funding commitment, the effort will be rewarding. It will be easier and pleasing for us to reach our goal. Thank you very much.
Good news. Every year Nigeria produces 6.7 million children. Wonderful. The population of Togo is actually less than this. The bad news is that out of these children, about approximately 500,000 will not even celebrate their first birthday. Next. 734,000 will never celebrate their 5 years. I mean, they will not be 5. I mean, it's terrible. Then finally, the process of childbirth of 42 days after, or maybe during pregnancy, or 42 days after, approximately 54,000 mothers die. That's how terrible it is. Our observation next is simple. In terms of resource allocation, if you look at this category of people, children, mothers, and more active mothers, and mothers to be, that means pregnant women, they make up about 60% of the entire population of Nigeria. Next. And the challenge, why they're dying, people are losing life, people are crying, family, to put it in context, we have just about 35,000 families. Out of that family, every year, almost about 1 million will have to weep because of all these things. And it's because of just these 3 basic things. Enhance awareness, and we lack that. We don't have good, or I won't say, well, we take training of health personnel, and finally improve quality of service. So I'll be taking my feed from those 3 basic perspectives. I know they actually stretch beyond this, but I'll be talking about just those 3. Next. Now, if you look at the budget as it were, we have 4 basic classifications for the budget. The MD allocation. If you look at the allocation for the MD this year, there's just about 3 trillion. The entire budget is 6 trillion. So if we focus our attention on just that, we may not get results. The second one is the service-wide vote. The third is actually capital supplementation. That's when you have the constituency project. And finally, you have statutory allocation. That's when you talk about the National Assembly and other allocation. Next. Now, we're going to talk about funding, theory. We are going to spend 6.6 trillion this year. But if you look at the funding gap, it's just about 3.8. That means you're going to be borrowing to do this. Next. Now, in terms of priority, this is actually the budget that was passed by the National Assembly and sent to the President. The first priority of government is interior, which is security. The second one is about infrastructure, works, housing, power. The third is talking about defense, security. The fourth is talking about education. Then the fifth line, that's where you talk about health. That means in terms of priorities, the government is putting this as number 5. Next. Now, this is the budget for the Ministry of Health this year. Capital expenditure, 28 billion. This has passed by the National Assembly, and the other components are just recurrent. Well, I won't complain yet, but if you look at this is where my problem is. The trend of allocation has actually been falling. So what has been happening in terms of improvement is about overstretching. That's my own submission, and it'll be wrong. I think we should give our health practitioner, they've been working with tight budgets and they've been achieving results. It's not as a direct impact of spending by government, but rather it's as a result of maybe improvements in terms of training. So next.
So if you look at the capital supplementation this year, I just quickly pull out some two things. Counterpart funding, including global funding, including global fund and health, you have 3.5. Then provision for SDGs, which you have health as an integral part of it, 3.4. But this information are not disaggregated. So sometimes we may have this entire money may not even be going to health. Next. Now, 2015, the Nigerian Bureau of Statistics claims, well, I say claim, Nigeria actually spent 682.7 billion on health. But if you look in close terms and look at the budget, how much was spent for maternal, newborn, and child health is actually just 10.2. If you look at the budget and you start pulling it out, you can affiliate with it. It's just 10.2. You see the wide gap between the two. Next. Now, in terms of awareness, number one, I said I will be talking from pay perspective. There is absolutely no coordinated budget or program, and I'll get to that, to actually get this done. For instance, it's very pertinent to see mothers, pregnant women, to actually start going to hospital very early stage. Before 20 weeks. That's the policy, right? But have you ever seen anything in terms of awareness to actually promote that? No. Definitely, I don't know. We may do it on TV, we may do it on radio, simple jingles, but it does not resonate because I have not had one. And I listen to the news, I do this thing. So if you go to the village, you'll be so surprised. Nobody know about this. And then sometimes you continue to blame these people. So the government has not done anything about this. And it's terrible. Next. If you look at the mandate to actually do this, falls under the National Orientation Agency in terms of coordination. The Ministry of Health may not be skilled in communicating these pertinent issues, but the National Orientation Agency should do this. Unfortunately, next, if you look at this year's budget, there's absolutely nothing about it. So you left yourself to actually do that. Next. In terms of training of health personnel, I think the first thing you look at is the teaching hospitals. Let's go to the teaching hospitals. Next. We've not seen any direct communication in terms of effective, different strategies for training these people. Next. And if you look at the allocations also, you can see 2016, we're coming down again. If I could take the analysis across board, you will notice that in actual fact, spending to train health personnel has been falling in Nigeria, except maybe for last year where you had a little bit of job. Now, in terms of budgetary allocation, there is federal government direct impact. When you talk about child health and vestibular centers, let's look next. You notice something. In 2015, you have 1.95 billion. In 2016, 1.99 billion. And this after a lot of shout and a lot of this thing. So next. Now, I don't want to inject figures for 2016 because the budget breakdown is not yet out. All we have now is just the framework. But for 2015, 10.5 billion will be spent on 60%. It's terrible. So 2016, if you look at the proposal, which was the president's communication, it is less than 4 billion. So if we decide, so we will assume that maybe because of the budget padding and other things, so let's leave that out. Let's go. So if you go to state budgets, okay, federal government, they give us it. If you go to state budget, the reality is that all you see is just blanket figures. There's no coordinated. In fact, if you look at the figures, it means nothing to anybody. It's just an information. Just know that this is going for it. Next. For instance, if you look at the Lagos State budget this year, all you see is 42.3 billion, and that's all. Capital expenditure this, recurrent expenditure this. If you want further information, go and beg somebody at the ministry. Nobody gives information in the budget. So next. So I think the key thing to actually finding funding source is actually to open up our data set. And we try to connect those data that we open up to activities, and from activity it fits into planning, and then with that you can now begin to fund. And I will leave with one simple illustration. Funding education in Nigeria was affiliated and connected to tax. If you look at it closely, there is this education tax form.
and it helps a lot and did it. If we can actually affiliate some of these advocacy lines that we are drawing, say, okay, if you want to increase value-added tax in Nigeria, why not just use 2% just for health, rather than looking at it from that perspective? I think that would be the best way to actually penetrate through this thing. Thank you.
So I want to make a very snappy presentation here, and I want to start from two backgrounds. Number one, the previous presentations have told us that finance has been sought for, and so it's a major challenge to FP implementation in Nigeria. Two, that the blueprint we are talking about, actually was finance-based, not activity-based budgeting or costing. When we take our journey from these two sides, then there is a need for us to do what we call activity-based budgeting. And why are we doing this? We are doing this because most of the donors are interested in funding activity-based costing. So, next slide please. I would want to, so what my presentation is simply to give you an update on what we call financial gap analysis. The objective of the financial gap analysis is actually to undertake a journey into the field to determine the financial requirements for the blueprint based on the activities that are actually planned to be implemented and available funds within government and donors. By the time we have the available funds as well as the financial requirements, then we'll be able to establish the gap, and that is the essence of the gap analysis. So the objective is simply to establish the gap between what the requirement is and what is available. I hope I've sent the message very clearly. Okay, so next slide please. So in order to determine the gap, what has the Federal Minister of Health, in collaboration with some key partners, been able to do? In 2012, the Federal Minister of Health, like Dr. Afolabi said, we look at the commitment, federal government committing to increasing CPR by 21% in 2018 from the current level as at 2013. As a result, they have conducted what we call a family planning landscape analysis. In 2014, they developed a costed implementation plan, that is the national blueprint to achieve the 36% CPR. Next slide. Now, to take up, the Federal Ministry of Health went ahead to develop what we call an analytic model to disaggregate national CPR goal to the 36 states. Dr. Folabi gave us that one. Besides that, activity-based matrix, setting side-by-side activities was developed by Federal Ministry of Health. The blueprint was reviewed that informed this activity by activity based costing in order to establish what we call the financial gap. So today, if you look at the blueprint, the $603.3 million that is contained in the blueprint, when you compare it with the activity-based budget that is done, you will discover that the activity-based budgeting has a higher value than that one. Next slide. So what is happening now? Federal Ministry of Health, together with key partners, have actually developed a tool that will be used to go to the field and gather this information using from partners. Two technical advisors have been recruited in collaboration with Federal Ministry of Health that will undertake this assignment on behalf of Federal Ministry of Health. Next slide. I've told you that the family planning financial gap tool has been developed. The plan now is to go from one major stakeholder to the other by these two technical advisors along with staff of Federal Ministry of Health to meet with them to determine what the amount of money that such stakeholders are ready to commit to family planning implementation in Nigeria based on the developed activity. At the end of the day, findings from the field will actually be articulated into a final report that will be shared at a national level meeting to be organized later. I told you that I'm going to just have you only 4 minutes presentation. Thank you.
My name is Comrade Lucy Ofio. I'm a Vice President of the Nigerian Labour Congress and Chairperson of the Women Commission. One key issue that I want to bring out from all the presentation is the aspect of really when the second to last speaker talked of the role of the National Orientation Agency in this whole thing. I expected that they should be represented because they are major stakeholders. The problem I think the ministry is having with getting the budget or budgeting for family planning issues has to do with lack of awareness. People don't really know what is being done or what they should do, especially at the grassroots. Unless these issues are put on the front burner, right from the constituencies, it becomes a major issue. Even when the budget goes to the National Assembly and they want to prioritize, they may throw it away because it affects women. Because it affects women, that's the reality. Recently, the issue of violence against persons was thrown away with ignominy at the National Assembly because of ignorance. And because they think that it's not an issue, it's not necessary. It's the same attitude they are using too for issues that have to do with maternal health and child rights in this country. So the National Orientation Agency needs to begin to propagate, put this issue on the front burner, so that even our representatives at the National Assembly, they begin to hear this thing. The people are talking about it from their various constituencies. But when it comes to budgeting, they know that this is one issue that they cannot play with. And then funding will not become a problem. We can't continue to depend on foreign funders to help us to push these issues. I think the issue of family health and reproductive health is a fundamental issue that has to do with life. And then looking at the resources before us now, we all know that our economy has been a single based on oil, and the oil has dropped. Therefore, as much as possible, they want to cut everything. And they feel that anything that has to do with women is not a priority. Thank you.
I will be speaking with particular reference to the board chairman, Ajisa. Thank you for the comments you raised, and then just one or two. He talked about the preference of community midwifery program over MSS. I want to say the two go together because statistically, looking at what the National Primary Healthcare Development Agency presented on progress made based on a midwifery service scheme, it engages retired midwives who are very experienced, unemployed midwives, and fresh midwives. And the fresh midwives also use that platform as a kind of internship for them. About 1,000 each year are posted to primarily the community and primary healthcare centers. So it brings manpower and skilled manpower and quality care into those places. Now, for the community midwifery program, I know Zamfara has started and Sokoto has started. About 3 states in the north have started, and they are going to work together. It's integrated so that they can provide quality. Now, for the Ministry of Health, it's not a good thing that we're getting to know the MSS budget was not included, because if what the primary health care statistically are telling us, it has contributed largely, especially in family planning, nationally on average, over 200% improvement in family planning attendance. And then in the northeast, the northwest, especially in the north, I took time to bring that out. They have far above 300%. Like the north central has well over 500% in family planning attendance, and the northwest has over 400%. The northeast has over 300%. That's 313%. And that goes also for the antenatal care as well as the delivery. They are well over 200% in each of those regions. And that's courtesy the MSS. So I believe that if we're going to be pushing for something, we should be pushing side by side, especially MSS, because the program that is ongoing, yes, the National Partner Health did an assessment on attrition, availability, and sustainability. That's for 2014. And it was encouraging because, thank you very much, sir. Just less than 20% we had attrition rate. So there are many people who are still willing to work. But the problem, the issue there has been the salaries. Most of them have not been paid for 6 months, 8 months, by the federal government, by the state government. In fact, state government is over 2 years, some of them have not been paid. But funny enough, those guys are still in their facilities. Not all of them have left, even up till now. So that's really commendable. So I want to say to the federal ministry, it's good for you to look not just at including the budget line for the family planning, but also that midwifery service scheme budget should also be looked into. Thank you very much.
Now he wants us to talk about the men involvement. Now you find that most of us here are men. And again, it is the men that make the women pregnant. And then when it comes to handling the budget, it is the men that handle most of the budget, both at the federal level, state level, and local government. It is most of the chief executives at these three levels are men. And so the women are incapable. And you look at the culture, most decisions in Nigeria are made by men. And we have been talking about funding. Let us look beyond federal level. Most of you representing the states here are men. Please, men. It is no more business as usual. I work for Nuri Project. I am Charity Bauchi. At the state level, we've got states to spend money on FP. In all the states Nuri Project has worked in, over 80% of the LGS headed by men are spending money on family planning. There are budget lines, there are consumables where we are working. And what we are saying is, if you men are our partners in reproductive health, on sexuality, communication, interaction, please, when you go back, let's do this, take decisions in an unusual way. We need to have quality family planning services. There is a limit to running away or sweeping everything under the carpet. There must be money for family planning. And then at the state level, federal level, local government, if there are challenges, the technocrats, who are mostly men, are facing with regards to funding for FP, let the advocates know so that we can advocate to support you to get your businesses on course. We cannot afford to have Nigeria dominated by men, decisions made by men. Our president is a man. And then when it comes to political discourse, it is the men not having family planning as a right for every couple. Kenya reviewed their constitution in 2010. Kenya has family planning written in black and white in their constitution that family planning is a right of every citizen. Nigeria needs family planning. We cannot afford to continue to hide and pretend. All religions support family planning. We've got Islamic perspective, and we're on course now to have Christian perspective for family planning. And by the end of this year, we're going to have that booklet. It will be available. Please, men, get involved. We need you to save the lives of our mothers.
Okay, sorry, my name is Salis Ibrahim from the Media Action for Persons with Disability. Okay, the presentations have been quite good and educative. And Initially, I wanted to speak about disability and male involvement, but I think my sister has said all about male involvement in this family planning. What I would like to suggest here is that existing policies need to be adjusted, and newly formulated policies need to be considerate enough to include people with disabilities in the family planning related issues and policies. This is because of the fact that people with disability are already exposed to health and poverty challenges. With these, if they are properly educated, informed and enlightened by providing information accessible to them in all available alternative formats, I believe the messages will be more useful and productive. Thank you very much.
I know, yeah, we get carried away by this concept around capital recurrent expenditure. If you look at health closely, health is practically service-oriented. As such, I think our focus should be on quality of delivery, not necessarily capital. For instance, if you build an hospital, definitely you need to recruit personnel. As such, personnel costs will also run up. I think advocacy around health should be more focused on quality delivery. And if we look closely at the National Health Information System, I think we have close to 150 or even above indicators with clear-cut targets on what to actually achieve. I think if we can actually adjust our budget in line with those health information systems, it will help us to actually drive what we are getting at. I think that's just my little additional comment.
When the issue is no more making provision for family planning, sometimes they can give you as a single line. Sometimes they embed it as a reproductive health. But the problem has always been approval. Where they approve, very hard for you to get the money. So that's the issue. And it's worse now because of the dwindling resources. No approval, not just family planning. Even immunization, no longer do we receive approval.
I'll be very brief. Just in line with the question you asked. In our state, we are very, very happy that we have the primary health care agency now. We kickstarted last year, and at the state level, there are enormous problems. Just like you mentioned, family planning issues were not, in fact, given any priority at all. We're not even talking about release, but even the budgetary allocations were not even there. But as I said, we're quite pleased that we have the agency on board, and we are not with the ministry per se, and we have the independence of deciding these things. And I'm happy to say that in our budget, which is almost being passed into law, family planning has been given the necessary attention. But I defended the budget, and family planning had the highest allocation after immunization. Yes. Now we defended it, and at the House of Assembly too, we are happy because most of the members were, two of them were our staff from the Ministry of Health, and we had no problems. I think the major issue now is to advocate with the governor. Now, once that one is done, and once we are able to achieve planning under one roof, I think family planning issues are going to be given the necessary priority. Thank you very much.
We talked about male involvement, and I think there is this saying that if you keep doing one thing and keep doing the same thing and getting the same results, then you need to examine your head, isn't it? We've been talking about male involvement in family planning, and we're not getting any positive feedback. Maybe we should try to repackage the message so that it will resonate. And one of the key things I'm thinking that we should start looking at is, let's talk to the men about the benefits the man will get
I don't know if people appreciate what I'm trying to say here. The benefit the man will get if the wife is healthy and the child is healthy and he does not lose his child, he's able to train how many children he would have. Maybe that will resonate more, and then eventually the woman will benefit, isn't it? It's called reverse. There's something reverse something they call reverse logic or what. So with that, I want to thank you for listening, and I'll hand over to Dr. Kayode to close the session. Dr. Afolabi, sorry. Thank you.
I think it's just left for me to thank you all for your attention, robust participation, and patience. It's been long. We have delayed your lunch a little, but you have really participated so well that I'm impressed, and I owe you that gratitude. I think that was a very good one from the Executive Secretary, State Primary Care Development Agency, Plateau State. But there is another area I would like those who are from state to look at here. At the operational level, family planning is still being treated vertically, which is very counterproductive. There were some service delivery points that I visited. They had commodities, they have consumables for immunization, for some other interventions. But FP units in the same facility did not have, and they were not allowed to access this consumable from immunization and antenatal clinics. I think you should also look into this and integrate fully family planning services at the level of service delivery points.